Hi there.
Hi,
Hi,
Janin,
Sandeep.
and good afternoon, everybody. Can you have the slides, please? This is a young man with proven chronic calcific pancreatitis on medical management. About a year ago, he presented with obstructive jaundice, mild obstructive jaundice, but his CBD was dilated on imaging, and the LFT was showing alphos, which was about 1.5 times above normal. And imaging showed dilated CBD with distal CBD stricture, as you expect in some of the patients who have chronic pancreatitis. This was the image that he had, a lower CBD short stricture with some calcifications in the pancreatic head. So we have placed a plastic stent at that time, and he has required few exchanges in between. So the plan is now to look at more permanent or semi-permanent options for benign biliary stricture and setting of chronic pancreatitis. Conventionally, we have been using multiple plastic stents or a fully covered stent. Today, we'll show another type of a stent which also can be used, a biodegradable stent. There are several varieties available. These are complex carbohydrates which dissolve with natural enzymes, and they have a lasting effect for about varying from the carbohydrate which is used for 4 weeks to 3 months. So the stent that we have selected is a balloon expandable biodegradable stent. You have the endoscopic image. So this patient
Yes, we
already
have
had
the
a
endoscopic image. Yes, we see the papilla.
Yes. So, and we have passed a guide wire inside. So we'll inject some contrast to demonstrate the picture. You have the fluoroscope image now. Fluoro, please.
Yeah.
Yes, please. I will. So you can see this picture lower down. I'll pull back.
I think it's a very nice trick you do. If you have your scope blocking your fluoro, that you push in your scope so you can really nicely see the distal CBD instead of changing the fluoro.
So before we came on the screen, we also did a pancreatogram. He has a pancreas divisum. So the aim is his pain abdomen from chronic pancreatitis is not so much, unlike the other patients, but he has a biliary obstruction, which is the main problem. So we'll now exchange, remove the sphincterdome, leave the guide wire inside, and I'll just show that stent to you outside. Can you open that stent, please? Yes. This is called as Unity B stent, which is from AMG company. And this stent comes in 3 diameters, 8 millimeters, 9 millimeters, and 10 millimeters. And depending on the diameter that we wish to choose, the length is standard. It's 57 millimeter to be precise. And this does not shorten or expand as we place. Can you show that, please? Oh, okay. The design of the stent delivery system is that the wire, when the assembly goes in, it has a balloon first, and on top of a balloon, the stent is crimped. Can you focus on this side? Yes. When it comes here, I'll show you. You put on the wire. It's loaded.
And maybe, yes, exactly. Nice to have it really large. Brilliant image.
Thank you. Cap it. First cap it. So it should not directly go in the cap of the scope because the stent is on the topmost surface and it's a little fragile instrument. So we need a transparent cylinder which is fitted into the cap. Can you see that? And
yes,
through this, the stent would go in. Yeah. If you directly place in the cap of the endoscope, it may get damaged and the work may not happen. Just stop it here. And if the cameraman can focus here, you can see a shiny thing. The surface topmost part is a stent, and this is loaded over a balloon. It's a cylindrical balloon which is inside the stent. So we'll gently pass it across without rubbing against any of the side part. And also we'll keep the elevator down because that's another area where the friction can occur. So no friction should occur when we pass this assembly over the guide wire.
And what are you afraid of if friction is occurring? What's happening?
Yes, yes. Wire tight.
I mean, is the balloon going to be damaged?
No, the stent. The balloon inflates the stricture, and the stent also expands over the balloon, and then the stent is released there, and the balloon is deflated and pulled back. Stent remains in its position. So this is a little more crucial situation. I'll keep the elevator down, and you'll see a little shiny thing coming out. Can you see that?
Yes, we can. That's really nice.
Of a thing.
And maybe we can get the endoscopic image a second large so we can have a closer look.
Endoscopy large and fluoroscopy small. And this stent has two radiopaque markers at both ends. So two at the distal end and two at the proximal end.
I see you very carefully moving in, and you really do not want to have any friction at all.
Absolutely. And now we will inflate with contrast.
Okay, so then we can have.
So you see the markers on the two markers the radiographer is pointing out, one above and one bottom.
And I think for that we need
we'll have
a bit larger, please.
Fluoroscopy large.
Yes, inflate.
Fluoroscopy large.
Yes, now we can nicely appreciate the markers and also immediately the inflation of the balloon.
Keep it inflate. Slowly, stop. Little more. Stop there. I think this is okay. So we won't go too big. We can go up to 8 millimeter or 9 or 10, little bit more. We have to adjust according to the bile duct as well. Little bit more. Stop. And we'll keep it inflated for about a minute or so.
But that's incredibly long. How are you going to manage that? What are you going to do in between?
Up to you.
Usually he has a cup of coffee in between.
I would say so, yeah.
One sip.
Or a dosa or so.
Yeah. Samosa.
So the aim is to dilate as much as we do normally for any stricture, which is about a minute or so. And then we deflate the balloon. The aim is to deflate it completely. Again, there should be no friction between the balloon and the stent. So this stent will keep expanding. It's expanded now fully with the balloon and remain at its position and before it starts getting dissolved. So the expansile area remains in situ. So the continuous permanent dilatation remains for at least 3 months before the stent starts getting degraded.
And how is it with hyperplasia? I mean, we know from other degradable stents that they might give tissue hyperplasia. How is your experience with this one?
That's a great question. So there have been some animal experiments done before and some human experiments too with a similar complex carbohydrate, which is the secret of the company. And it has not caused any tissue hyperplasia. Some of the earliest stents that we have placed, we didn't find any tissue hyperplasia.
Oh, that's great.
The only major advantage which I foresee compared to other contemporary stents is that you don't require a second procedure to remove the stent.
And how is it with the force? How is the expanding force of it? How much pressure does it give on the surroundings?
So it doesn't give any more radial expansion except for what balloon is giving it now. Now you can deflate.
Yeah, so it's only the initial expansion that occurs, Janine, and afterwards it stays in the same expanded state. It doesn't collapse. And I think the important thing is, like Sandeep was mentioning, how it dissolves. We find that the earlier stents were dissolving in different areas separately, whereas this is uniform dissolution, and that's why the hyperplastic tissue problem is much less, although we don't have much experience with pancreatic stents of this nature. The pancreatic stent is a different one, which doesn't produce so much hyperplasia.
If you do not deflate enough, I can imagine you pull out the stent when you take out the balloon.
Absolutely. That's why I'm just staying there. I'm not moving at all. And with contrast, it's a little more viscous than saline. And that's why it's taking longer time to get deflated.
Yeah, no.
So on X-ray, it's gone. And in endoscopic, it's a little crumpled. Okay. Yes. I think it got disengaged.
Yeah.
So the radiopaque markers can then be followed up on X-ray at serial interval to see if the stent is still in position or is it degraded out.
And I mean, it looks to me very interesting. Are they on the market, those stents, or only in specific areas in the world, or?
They are in the market, but I think they've still, we still haven't had large randomized studies. I think what we require to do, Janine, is probably a good randomized study comparing multiple plastic or completely covered stents with this in benign strictures. Until then, I think they won't be used so much. Nice position.
So that's the final position.
Very nice.
Okay, Sandeep, that was a fantastic job. I think we should move to the next room.
Thank you.
Where Mohan is ready along with a guest of ours, Jack, who is actually the inventor of this.